Okay, and I'm going to turn it over to Jessica Houston, who is the coordinator on this case, to give a brief overview of what you all reviewed and answer any questions about the case. Jess?
Thank you. Alrighty, as you can see from the CET form, Scott experiences a lot of anxiety and has had several traumatic situations that seem to trigger or increase his anxiety. Scott was referred to START originally because the family needed assistance because of the increase in anxiety that he was experiencing. Scott has not seen his father in over a year, and he had shown up on Christmas Eve to the family home and just stared into the house from the front yard. This increased Scott's anxiety greatly, as well as his fearfulness, and caused a continued fear of his father showing up to the home, as there is a history of trauma and substance abuse with the father, which seemed to have motivated the system to reach out to START. The referral to START also stated that his current living environment is not the best, as he lives with his mother and his maternal grandparents who are sick. Scott is diagnosed with anxiety and major depressive disorder, as well as mild ID. He also has medical concerns, including constipation, digestive issues, and high cholesterol. So Scott was born full term at 6 pounds, 2 ounces, and he had complications of jaundice following his delivery. As a baby, he was described as very clingy and had difficulty sleeping and was difficult to feed and comfort. He was fussy much of the time and would excessively cry and be overly active. He began early interventions at the age of 3, where he received speech and OT. In his early childhood, there was noted sleep difficulties, as well as him not eating much. While in kindergarten, Scott was often made fun of and called stupid by his classmates. And he also repeated kindergarten in a 12-1-1 class and continued speech and OT. Throughout Scott's childhood, there were several ER visits and psychiatric hospitalizations due to depression and anxiety, as well as suicidal ideation. He had an aborted suicide attempt at the age of 11, in which he was utilizing a rope. At the age of 12, he was diagnosed with generalized anxiety disorder, social anxiety disorder, separation anxiety disorder, a language disorder, and intellectual disability. At the age of 14, his mother filed for divorce from Scott's father, in which the father often blamed Scott for. The divorce was due to the father's substance abuse and erratic behavior. There's been several incidents since the divorce where the father has shown up at the home unannounced and has also been consistently reaching out to the mother via email demanding to see Scott. There's also been at least one time since the divorce that the father reached out to Scott via a video game chat. And he had reached out to him to try and encourage him to attend an upcoming wedding for the father's side of the family and expressed that it would be embarrassing if Scott did not show up. Scott was able to ignore his father, and the system worked together to ensure that the father was blocked from this type of communication. The mother had expressed that there is a lot of trauma involving the father's side of the family, as Scott would often need to parent the adults at family gatherings, as they would be under the influence and often need assistance being brought to bed. Throughout Scott's childhood and early adulthood, he has struggled with attending school consistently and often would experience vomiting due to the stress. Scott is often seen as a rule follower and having a high moral compass and wants everybody to follow the rules as they are dictated. He would often tattle on peers if they were doing something that they should not. And he has also struggled with boundaries at school with classmates as they see him as vulnerable and would ask for money or his belongings. When he was 17, his maternal grandfather, who he lives with, suffered several strokes and was diagnosed with dementia and cancer, and is currently wheelchair bound and becomes confused often, which is a stressor for Scott. Before being prescribed Remeron, Scott would often not sleep and check on the different family members throughout the night to ensure that they were breathing. In a recent CSE meeting, the system discussed having Scott attend BOCES full-time to further support him and his anxiety with school and provide a supportive environment that he finds enjoyable. He also recently started working at a restaurant on Saturdays, which he finds beneficial, and he is interested in working once he graduates. He was also recently accepted into a program for the following school year, in which he'll be working at a nursing home, and this will be able to have him explore his strengths, skills, and interests further. And that's all I have for Scott.
Great. Thank you so much, Jess. Does anyone have, excuse me, any initial questions or thoughts from what you read or what Jessica reviewed? All right. If there's no initial questions, then Dr. Kett and I will start the training. As I stated earlier, at any point, if there is a question or a thought that you want to share, feel free to unmute and join the conversation. I also will keep an eye on the chat box periodically if anyone wants to put a question or a comment in the chat. I'm just going to share my screen. This needs to go away. There we go. All right. So the topic for today is understanding anxiety from the biopsychosocial perspective. Obviously, Jessica reviewing the case and what you guys reviewed. Scott is a perfect case to review the anxiety topic with. And as I said earlier, our hope is that we all will learn from this presentation and incorporate our own expertise that we have and come up with some recommendations for the system moving forward. So to start, symptoms of anxiety. Anxiety is a universal human experience. Everyone experiences anxiety at some period of time. As an infective state, the symptoms of anxiety include a sense of discomfort and uneasiness, arousal, a fear, and a need for escape. Anxiety disorders are characterized by symptoms of sufficient intensity to disrupt social functioning. So, as I said, everyone experiences anxiety at some period of time. It does not mean that everyone has an anxiety disorder. So that sufficient intensity and disruption to social functioning is very important criteria for an anxiety disorder. Generalized anxiety disorder represents an exaggeration of uncertainty about competency or future threat. We will go over several different types of anxiety, and as we heard from Jessica, Scott himself has multiple forms of anxiety. He has social anxiety, he has generalized anxiety. There was quite a few in that list.
Hey, Elise, I just wanted to point out something. I always think when you give a talk on anxiety, it's important to remind people that anxiety has a purpose, that evolutionarily it was there so an organism could survive. We're supposed to get anxious if there's a large pterodactyl who's going to eat us, or, there's a flood coming our way or whatever. So the point is our body is wired for a purpose to be anxious, but when it becomes a disorder, it's an inappropriate use of that wiring. But I always think it's kind of just important to throw that out, that there's a reason to come to that. Yeah. Absolutely.
So thinking about anxiety and developmental disabilities, comparing the neurotypical population and this population. So the frequency in the neurotypical population is about 15 to 20%. The frequency in the developmental disabled population is 40 to 50%. So high prevalence may relate to not only to poorly resolved stress, but also genetic vulnerabilities. Among persons with developmental disorders, anxiety may result from cognitive impairment, reduced adaptive behaviors, increased vulnerability to environmental demands. Decreased social skills and dependency on familiar others may also lay the groundwork for reported high rates of anxiety. As we know, a lot of the population is dependent on their caregivers, whether it be paid supports or family, in order to live their life, whether it be for their medications, for their day-to-day activities. And the anxiety that they could have based on that dependency is very high. The high prevalence of anxiety may relate not only to the poorly resolved stress, as well as the genetic vulnerability for anxiety disorders. There's also an issue with recognition of anxiety in this population. People in the population may have a lack of skill for reporting symptoms. They may not have the communication abilities to indicate to others what they might be feeling. They may also show an incongruent mood and affect. What we can see in their facial features or their nonverbal cues might not match what they're actually feeling inside. We also might see symptoms that are more related to aggression and physical symptoms when the underlying vulnerability is anxiety. For anyone not familiar with the Diagnostic Manual for Intellectual Disabilities, or the DMID-2, it's an incredibly useful source of information. So as we know, the DSM-5 diagnostic criteria relies heavily on adequate cognitive function and communication. Within the population of IDD, those things are impaired. So by using the DMID-2, we're able to apply the criteria of the DSM-5 to people with intellectual disabilities. They take all of the DSM-5 diagnoses and apply the criteria to the different levels of ID, so mild, moderate, severe, and profound. It will give you information of how to adapt the criteria. It also provides a lot of research of each diagnosis within the ID population and gives you the support in making sure that you're having an adequate diagnosis. All the references to fear should include that fear can be observed by the informant rather than subjectively described or self-reported, as an example. So it talks about, for example, with a diagnosis of post-traumatic stress disorder, criterion A is about their ability to communicate that event in the DSM-5. In the DMID-2, there's an adaptation for that because the communication skills may impair their ability to communicate that. So we want to make sure that anyone that is working with this population is aware of this manual, as it is really helpful. And oftentimes we at START try to really introduce this to the providers in the community as they do get misdiagnosed. And oftentimes things like anxiety might get missed because they're just focused on the aggression that we're physically dealing with.
Okay, so I thought it'd be interesting to go over some of the features of anxiety and even looking at the regular, typical DSM. So for generalized anxiety, you clearly see excessive worry. And to make the diagnosis, it has to be more days than not and for at least 6 months. Generally, it's about various topics. The person doesn't only stick to one flavor of anxiety, but you also see some other common symptoms. And to make the diagnosis, you need 3 of the following. Restlessness is very common, easily fatigued. And I love that one because as a psychiatrist, a lot of times I treat anxiety and people complain to me that my medication made them tired. And in fact, it may have, but to be anxious all day makes you tired. You know, if you're fighting a rough day, you come home, you're tired. So that's, I think, something we need to keep in mind because we commonly see our individuals that are complaining of that or showing low energy. And we need to remember anxiety does that. Difficulty concentrating, that's also a GAD symptom, which of course overlaps with attention deficit. Irritability, muscle tension, and sleep disturbance. And as Elise said, these have to cause clinically significant distress in social, occupational, or other important areas. Now, in terms of the ASD population, a couple little things you look at in addition is you want to see if there's an increase in stereotypical behaviors. If they're anxious, you may see more of the self-stim, you may see more sensory discomfort, and more of that fear that she was talking about, a sense of being threatened. Phobias, not uncommon, fear of a specific nature. The deal behind that is that they're fairly intense and irrational. There is no real danger. And I'll never forget, we had someone at START, I don't remember, he was afraid of orange. I don't know what happened in his background, but he would not wear orange, see orange, anything about the orange set him off. So although you might be able to trace back a reason, in the present, it's an irrational fear. And one that I see in my practice all the time is birthday party fear. They're afraid of the balloons popping and they're afraid of the loud sounds of singing happy birthday. So we have to take into account sensory stuff when we look at phobias as well. Now, OCD, I think everyone knows, is intrusive thoughts. Now, those are the obsessions, but you'll also have to look for the compulsive rituals. Those are the actions. And generally, these things are to prevent something bad from happening or to ward off some bad thoughts. The overlap with ASD is a little bit tricky because, of course, we see these kind of things where sometimes it's helpful to distinguish them is that an individual with OCD, they tend to find it annoying and ego dystonic. They kind of don't want to do the rituals. They'd rather get rid of the thoughts. where in ASD, sometimes it's more soothing and it's a way to deal with the anxiety, but it doesn't bother them as much that they're doing it. A lot of times I'll get a complaint from a family, hey, my child is just, wants to watch the same video over and over again, or has to have the same conversation over and over again. And it's not that bothersome to the individual. It's a little more bothersome to those around them. Social anxiety. Well, if ever there was a setup in ASD and IDD, it's going to be here. Because again, back to what Elise said, the communication skills are going to be off. They're not going to read the situations as well. They're not going to be able to say what they're feeling as well. They're not going to, know what's coming back towards them. So you're going to see that vulnerability to fear. And that's why very often the consults we get at START, we look at the history. Are they with new people? Or are they in new places? So when you see those changes, you're going to see a huge flare up. And it's not just good old fashioned social anxiety, it's responding to that change.
Okay, so the chart that's on the screen and in your PowerPoint that we sent out really just gives you an understanding of maybe some typical responses to anxiety, what we might see behaviorally, what the emotion might be behind it, some cognitive thoughts, and maybe some psychological situations. So if we go across for avoidance, we might be seeing the behavioral symptom of avoidance. They might be feeling apprehension. They might be thinking, what happens if, and, going through some of those question marks, like the birthday party, what happens if the balloons pop? And then they might be having some problems with concentration as well. Escape, they might be looking just to escape an event, but underneath that, the vulnerability is related to distress. Their cognitive thoughts might be about not being able to leave an environment, and they may be having some memory difficulties. If they're engaging in unhealthy or risky behavior, there might be some nervousness. They might want that certainty, that definitive answer. They may be having some depressive symptoms, hopelessness, lethargy, or poor appetite. Overattachment could be related to panic, and limitation of daily activities could be related to worry.
All right, I wanted to basically...
Hi, it's Lori. I wanted to just, I saw that you left a message. Am I muted?
You are not muted.
Sorry.
That's okay. Go ahead, Andy.
All right. I was hearing voices, which I thought was one of my own forms of anxiety, but okay, I guess not. All right, so I wanted to basically, and I think we may share a little on this slide, but I wanted to mention a little proof of the biological perspective, because we hear that all the time. Hey, it's biologic, you're at higher risk. But you know what? It's a fair question to say, well, prove it. Why? What is that based on? Well, a couple things. There are some really good studies, specifically in schizophrenia and bipolar, of this running in families. They have great identical twin studies of twins raised in different homes, but they shared the same genetics. And the rate of schizophrenia, the rate of bipolar mimics each other. So it's not bad parenting. Clearly, it shows that. Chromosomal link. ADHD, obsessive compulsive, and tic disorders are very closely built and on the same chromosome. So that's why we see that comorbidity of those three things very often. If you have a mutation, you might lay over the other two. So that's another cause, another evidence. And the last one, my favorite research study, and I've mentioned it in some other lectures, but there's new people, is the Stella Chess study of anxiety in infants. They took hundreds of infants and they looked at how did they respond to a new nurse, a loud sound, people walking in and out of the neonatal unit, all that kind of stuff. And the way they measured it was heart rate, blood pressure, breathing rate, skin temperature, right? Because a 3-minute-old, a 3-hour-old is not going to tell you they're nervous. So they categorize them: big reactors, medium reactors, and non-reactors. And lo and behold, they studied these kids 7 years later. And what they found were the ones that reacted to the light, the noise, the perfume, the whatever, 7 years later had school refusal, social anxiety, you name it, all those type of anxieties. So again, unless the nurse dropped the infant on its head, it's probably really not bad parenting. They were wired. to be this way. And sure enough, it followed up. So I just thought it would be good to give a little proof of why there is the biological perspective.
Absolutely. Thank you. So going into the psychological, research has identified 4 important variables that predict the psychological vulnerability to anxiety. So these are perceived control, cognitive appraisals, cognitive beliefs, and cognitive distortions. So to start, perceived control, this is the lack of perceived control over stressful life circumstances. The research has shown that anxiety is greatly determined by a person's perceived ability to control potential stressful events. And it's important to realize that this lack of control may or may not be accurate, but it's real for them. It's their perception about their control. That's what's important. This perceived lack of control is highly distressing. Cognitive appraisals is simply meaning the way we evaluate and assess a particular environment, event, or situation. It's a key concept in understanding one's susceptibility to stress and anxiety. Cognitive beliefs. These beliefs include not only beliefs about the event itself, but also beliefs about one's ability to cope with and or tolerate negative events. So they may get more anxious and have more issues in this area if they don't believe they can handle the stress that they're under. Cognitive distortions, the last predisposition, is 2 of the most common cognitive distortions that may affect anxiety are the overestimation of a threat and the underestimation of one's ability to cope. The overestimation of the threat is related to the belief that an individual holds about the perceived probability or certainty of the event's occurrence, and often this type of cognitive distortion is called fortune telling. In general, in regards to the psychological vulnerabilities, the greater the gap between our estimation of threat and our estimated abilities, the greater the likelihood we experience anxiety. In the social area, biological and psychological vulnerabilities help to explain why some people are more likely than others to develop an anxiety disorder, but social vulnerabilities help to explain how it's possible that different people come to fear different things. Early social experiences can account for some of these differences. So thinking about the case Scott, he has a lot of biological and psychological predispositions that fall into these categories. But then socially, I know Jessica spoke about, the father who was a very large stressor for Scott, coming to the family home during Christmas time and just staring at the home, which ultimately led to him having nightmares about him coming into the home. I believe he was having nightmares about the father killing people, about him getting a DWIs or DUIs. So that threat and that social experience exacerbated his anxiety that he already was predisposed to biologically and psychologically. Before we move forward to the next slide, are there any questions thus far? All right. Andy, back to you.
All right, well, this slide is obviously a chicken and an egg, and what comes first. There are always the question with patients with anxiety. I'm worrying, so I get anxious, or I'm anxious, therefore I worry. Typical worries that we'll see with our patients: job, relationship, personal, individual worries. This week, no better than any other, pandemic, no better than any other, to talk about global worries, right? People worried about the world we live in, what's going on, climate change, you name it. So could be different forms of worry. But through the years, I've met non-worriers who complained about anxiety and actually had a kid like that who I always used to say, oh, go talk to someone, something's bothering you. And her usual response, of course, with due respect, was, well, you're an idiot. I don't know why people pay to talk to you. I don't need it. And then sure enough, she was correct. Just would be a reactor. And I have plenty of patients through the years. I've learned that their heart goes up, they breathe a little heavier, they just get edgy, but they truly can't come up with something that's bothering them all the time. So the question would be, if you put someone in therapy and you don't address that, it's not gonna work. Now, obviously, there's a lot of people where they occur simultaneously. And the other issue is where I was wrong, and I was able to tell my kid, no, you're the idiot, is that therapy then could be looked at, okay, so you're reactive, Well, how do you deal with that? Let's talk about self-soothing. Let's talk about calming, cognitive behavioral strategies. So both still serve a role. So what I want to come out of this slide is the sense that anxiety comes in both flavors. You know, if you think about it like the old ice cream cone, it's vanilla, chocolate, or a swirl. It could be I'm a worrier, and then I feel it, or I feel it, then I worry, or a mixture. So the question is, does it matter? And I've already shown that it matters for the therapy, but it also matters for the medicine. Anyone that's done consults with me since I've joined here can see I use a lot of hyperarousal meds, things like propranolol, things like guanfacine and clonidine, because those are great for those physical symptoms. The SSRIs, the Prozacs, the Lexapros, all those, you know, those help a little and those are great for obsessing. But if you have someone who's really not worrying, but their body's going haywire, and you could get, and I'll get into it in another slide better, but if you could physically calm their body down. So it does matter when you have an anxiety person coming in to try to figure out which is the flavor that dominates. Okay, blood glucose, I put that on here because hypoglycemia presents as anxiety. I don't know anybody here, probably either themselves or know somebody that, you know, didn't feel well, didn't stop to eat, worked out, didn't eat. What happens? You get tachycardia, you get dizzy, you sweat, and you panic. So it's very important. And when we look at our individuals, we want to match up their behavioral health symptoms to their eating habits. We want to know, is this happening when they haven't eaten? Do we think it's related to a long stretch of period of time that they've gone without? Did they change their diet? Did they go on a different medicine that affects the blood glucose level? So it's not unimportant to look at this anytime you see anxiety. This needs to be routinely considered in your line of thinking and questioning. Okay, comorbidity with anxiety. Well, mood disorders, of course, because if anxiety is bad enough, it's hard to face that each day. You know, you're going to get kind of depressed if every day it's just so much work to get through life. But again, also maybe there's that genetic combination that you were prone to both as well. OCD, again, the genetics, but also dealing with being a slave to rituals every day, not being able to clear your head. That can cause an immense amount of anxiety. And as I said before, OCD as well is very tricky to diagnose in autism, as there are so many stereotype movements and perseverative thoughts that we have to analyze and compare. And back to what I said before, look for ego dystonia. In the OCD, we want to see if this is very, very bothersome. If they're like, please help me, I don't want to do this. I wish I don't have to think this, as opposed to someone where it's just a part of their routine and in a sense, a part of their self-soothing. Now, dysthymia, I'm sure most people probably fairly familiar with it. That's more of a chronic depression of greater than 2 years. It's generally a lower level and less acute of an onset. It's more gradual. But think about what you see in it, because it is important and it may present differently in ASD. The mood's down, the sleep is off, the energy is off. As Elise said, the self-esteem, the competence, the confidence isn't as good. There's a little more sense of hopelessness and also some more difficulty in decision-making. So some of those things may be off to begin with, but they're going to be exacerbated if dysthymia comes in. Now with bipolar, you're going to see more cycling, more up and down of the mood, maybe a little bit of hypomania. And again, that's a little tricky because hypomania could look a little bit like anxiety. So sometimes you have to tease that out and see what you're dealing with. And the last two are not diagnoses that we at START particularly love, intermittent explosive and impulse control, because they're more descriptive. So, you know, they serve a purpose if you're doing an evaluation, you don't know what to fill out in the beginning, and you want to get paid for your services, and we have to give something to the insurance company. But bottom line, if these are the diagnoses, we want to look underneath, especially think about it, if it's our ASD ID population. And the reason why, well, their executive functioning is probably off. Their communication skills are probably off. So what's that going to do? That's going to lead, as we spoke to before, to increasing anxiety in a lot of situations. So if I'm increasingly anxious, I have no say over what's causing it. I can't communicate why I'm anxious. I can't communicate for you to stop it. I may perhaps have a trauma history on top of this, well, I'm going to be intermittently explosive and I'm going to have impulse control disorder. So if you want to label me with that, you can, but there's going to be a lot of steps that led to it that I think are going to be more valuable than just calling it this and going on, with that as the diagnosis.
Does anyone have any questions about these comorbidities before we move on to COVID and anxiety? All right. Oh, I forgot there was more medication first.
Okay. Yeah. Now, was there a question or?
No, it was just me laughing at myself.
Okay. Well, as long as it wasn't just you laughing at me, I'm good with that. All right. So I want to just briefly, obviously, we're not doing a medication lecture here, but just want to get into benzodiazepines a little bit because that really are the hallmark treatments for anxiety. The fear we all have in them, prescribing them, taking them, knowing people on them are what? Addiction, dangerousness of driving with it, and interactions, sedating, overdosing on it. It's a weird medicine class because they're overprescribed and yet they're underprescribed, and especially underprescribed in our population that we work with because of those fears. The most common ones are alprazolam, which is Xanax, lorazepam, which is Ativan, clonazepam, which is Klonopin, and diazepam, which is Valium. Just to give you sort of a, I guess benzodiazepines for dummies, like just a real quickie thing on this is some things to keep in mind, because a lot of times you get cases, you wonder why they pick one, why they pick the other. Well, diazepam was the first to the party. It's been around very long, a little more likely to cause depression. So in psych, we were taught, let's not jump in with that one because it just depresses the energy a little more, the mood a little more. They're very, very good for muscle spasm. So in my CP patients, my ones that may have prosthetics and get spasms and they're very uncomfortable, I'll tend to use it. But this is why you don't see as much of it. Clonazepam or Klonopin, it's good for seizures as Valium is. I should have said that. Diazepam also is good for seizures. The clonazepam lasts a little longer. So instead of 3 or 4 hours, you may get 6 to 8 hours. So it varies, but it's a little longer acting, which is a nice thing. Excuse me, lorazepam or Ativan. One of the differences there, it's partly broken down by liver, partly broken down by kidney. And the first thought may be like, all right, so who cares? Well, let's say we have someone with some liver problems and we don't want it to be as toxic to the liver. Clonazepam is particularly bothersome to the liver. So you'd want to go with the lorazepam so we don't need to worry about as much. And the only other thing I want to throw out in this slide is there are some long-acting versions. There are 2 on the market. There is alprazolam LA, and that you take either once a day or sometimes you have to go twice a day. And a new one came out this year for lorazepam. It's called Loreev, Loreev, and that's long-acting lorazepam. I have 3 people on it, and I am very tempted never to use it again, only because it's about 5 days of fighting with an insurance company to get it approved, because they don't think it's necessary, because they think everyone takes their meds easily, which I'd love them to come to one of our consults when they say that. But I just want you guys to be aware, if you have someone who needs these things but isn't taking them regularly, there are 2 options for once-a-day dosing now that didn't exist in the past.
I do think, and again, anyone that's been in either CETs with us or consultations with us in the past, dosing is so important. We see a lot of medications just in general that really only have, a life in the body of 4 to 5 hours, but it's only been giving 1 or twice a day. So the dosing is really important. And it's great to know that there's some new options in these medications for once a day dosing that will cover them for the full day. That's great news.
All right, well, this is my last one, which is probably good because I think my voice is running out, but I wanted to just do a little thing on clonidine and guanfacine, which I hinted at before, because these are anxiety alternatives. And while I said they're better for people with physical anxiety, let's not forget when your body's calmer, your brain's calmer. So don't think if somebody is also emotionally anxious, you can't use these, you can. So what do these do? Well, they originally came out for blood pressure. So they're very good at that. They're used in detox when somebody's coming off medications because it blocks those withdrawal symptoms. As I said, they're very good for anxiety. I use them in panic, and they are phenomenal for motor and verbal tics. So a lot of my Tourette's patients, I'll use it. To show you how good they are banned in Olympic sports where you have to like hold a gun and fire because it keeps your body calm. It means it keeps your mind calm. So it probably means the entire Russian team was on them about 2 weeks ago. But they are, I know I'm probably gonna get in trouble for that. Somebody's gonna come after me, but anyway. So they're very good for the physical anxiety, and secondarily, they're probably good for mental anxiety as well. So if you do have a system that either failed the other anxiety medicines or is refusing them, we can backdoor the treatment for anxiety by doing this. And sometimes they're more comfortable. Number one, they probably haven't heard of these, and they're not as fearful of the other medicines.
So anxiety in a COVID world, obviously something that all of us deal with, have been dealing with for almost 2 years now. Even though it's only been the last 2 years, there really have been quite a few research studies. At this point, there's 2 that are focused on major depressive disorder and anxiety disorders and the impact COVID-19 has had on the increased prevalence. 2 things that they have recognized as a reason why there's been an increase in prevalence is the infection rates, the daily infection rates, and the reduction in human mobility. So the impact to our structure, our routine, those first several months where most of us weren't really even leaving the house or going anywhere. They have learned that females were affected more by the pandemic than males. And there was an estimated, and there is an error here, 76 million cases of anxiety disorders globally. I know that during the pandemic, the start cases that we got, especially, even now, we're still hearing that it's related to the pandemic when the referrals are being made, but a lot of it was related to anxiety. Sometimes it was discussed as an increase in aggression or, reduced activities. But when we boil it down, it really all boils down to that anxiety related to their activities, their engagement. If they had a death in the family, which unfortunately we had several cases encounter, the changes in their caregivers, not having in-home support, not being able to go to school, etc. In December 2020, more than 42% of people surveyed by the U.S. Census Bureau reported symptoms of anxiety. This was an increase from 11% in 2019. So we're looking at a 31% increase that actually reported it to the Census Bureau. And I imagine there was more that it did not report it. Young people were definitely the most vulnerable to increased psychological distress. A lot of the research talked about their stronger need for social interactions. I definitely think that's a huge part of it. I think especially for our population, the younger individuals with IDD, having to learn virtually was very stressful. Not having their normal routines, their normal staff, having their normal activities. And then again, not having that social interaction. We're even seeing now, as things have opened up in the last, several months, especially, difficulty now in removing themselves from their parents or those that were giving them care during the height of the pandemic, because they were with them for 24/7 for probably a good year. And now having to actually interact with other people or leave the house has been extremely stressful. I know just in my own private practice, I was getting almost 5 to 8 calls a week for therapy services, and it was all related to anxiety in the pandemic. So a lot of people were seeking services more than usual and were affected and had an increased prevalence. Dr. Ken, did you want to add anything?
Yeah, I did. I just wanted to throw in the biological piece. You think about it, the inflammation aspect of it. And I don't know how many people got COVID, but when I did, what I saw was any area of weakness hurt worse. Like, where I had my surgeries were like unbelievably painful. And I went and I read some PET scan research, and the CNS inflammation acutely was pretty wild. So there was this acute increase, and I saw it in my practice too. But interesting, the long haulers, some of the scanning of the long haulers is showing a little bit more chronic inflammation CNS-wise in the brain, which again makes sense. So I'm seeing not only anxiety, OCD, but I'm seeing tic increase in some of my patients as well. So you almost wonder if it's going to be like a COVID pandas. where we're going to see certain people where it just triggers a longer term immune response that almost turns autoimmune. It's all playing out right now, but without a doubt, there is the environmental that people were trapped, and there's clearly the inflammatory part as well.
Absolutely. Anyone that knows a long hauler, unfortunately, I have one in my family, and they're actually getting services at the long hauler clinic through Stony Brook here on Long Island. And there's also one with Mount Sinai in the city for anyone out there. And every 6 months or less, depending on the symptoms that they're seen at that long hauler clinic, they're doing mental health screenings. So I attend the appointments with my loved one because unfortunately her memory has been impacted due to the inflammation in her brain related to COVID. And they do a depression screening, they do an anxiety screening, they're doing a trauma screening every time she goes. So they are really looking at that and the mental health aspect of how it's impacting long haulers, especially right now. Right, and that concludes our presentation. I am going to stop share and see if anyone has any questions, any comments, any thoughts. No questions, no thoughts. Any recommendations for Scott? Is anyone there? I see a few of you visually, so thank you. Dr. Kent's cat has joined us. Well, if there aren't any questions or any comments or recommendations, thank you, Jacqueline, for your comment about the information being informative and hearing different perspectives. I appreciate it. Next month, and Dorinda not being aware of the DMID too, you are very welcome. That is a resource that is really important in this population. So I'm glad that somebody learned that today. Next month, just for anyone that is curious, we will be covering digestive disorders and gastrointestinal issues, and the month following TBI. So I hope to see you all at our next CETs, and thank you for joining us today.
Thank you.
Thank you very much. Take care, everybody.
Bye-bye.
Bye-bye.